Kristen has been with Triad for 1 year in the role of Vice President of Integrated Care Initiatives. In this role, Kristen is responsible for statewide initiatives that foster health equity and reduce fragmentation in the healthcare delivery system for individuals with developmental disabilities. Prior to Triad, Kristen spent 8 years with an upstate social care network. The social care network started as a performing provider system under the Delivery System Reform Incentive Payment Program, where Kristen wore many hats. With the wind down of the DSRIP, the organization focused efforts on health equity for people living in poverty by creating a network of community-based organizations and implementing initiatives, including a closed-loop referral system, transportation program, and others that would connect people to needed community resources, such as healthy food, transportation, housing, benefits navigation, and more. In her role as Vice President for Strategic Partnerships, Kristen advocated both nationally and statewide to include health-related care, social care as a critical component of health. This includes bridging the gap between clinical care and social care and all of the associated data sharing the workflow complexities. Studies have shown that clinical care accounts for only 20% of a person's overall health, making integrated care initiatives critical to improving the health and well-being of the most vulnerable people in our communities. Kristen spends most of her career working in managed care administration, with the majority of the time dedicated to New York State Medicaid managed care, operationalizing regulatory changes, including Medicaid redesign updates, implementing preventative care, quality programs, and contributing to reimbursement program design. And now it is my pleasure to introduce Kristen Scholl.
Thank you, Nadira. So just to give you a brief introduction of what we'll be talking about today, I really want to focus on the 1115 waiver amendment. And so we've been calling it the 1115, but you might hear me say NYHER, which is the New York Health Equity Reform. So we'll focus on opportunities and concerns specific to Medicaid members who have an intellectual and/or a developmental disability. So next slide, Ian. So the goal for today really is to provide you with the information needed to participate in the 1115 NYHER projects. Success for me today is that you might be interested in learning more about this topic and then taking next steps to see how your organization can participate. So as you can tell from the name, this is a New York State health equity program, and therefore it's critical that those of us in the developmental disabilities field participate as robustly as we possibly can. So again, the focus today is on the NYHER amendment. There is a tremendous opportunity to serve people with developmental disabilities under this waiver. There are, as we'll discuss when we kind of get into the meat of this, people who won't be eligible, but there also are many thousands of people who are eligible to be served through this program. And I have heard many folks say that they think that we don't have a place in the waiver, but I just want to kind of myth bust that as we talk today, so that we can talk about how you can participate. Another thing that I'd just like to say is that I know many of you serve a wide variety of populations. So some of you serve people with behavioral health diagnoses and other folks. So as we talk through the 1115 NYHER waiver today, you can keep an ear out for how you might also be able to serve some of the other people that you serve. So then, just to talk about the agenda a little bit. So I'm going to kind of level set with you about the organization I work for, which is Triad, and slight overview of the CCOs, which many of you are very familiar with, but we have some other folks on the call who might not be. We'll then go into the 1115 Health Equity Amendment and opportunities and timeline as it relates to that. So before I really get started in the meat of the presentation, I want to just take a little poll to see who's on the call today. So you can see a survey up on your screen. And so if you could just respond to the survey and let us know by clicking, numbers 1 through 5, the organization that you most closely represent, whether you're a developmental disabilities provider, click 1, you're part of a CCO, 2, maybe you're here from a social care network, 3, 4, you're just here from some other sector in the healthcare delivery system, and maybe 5, maybe you're a consultant or you're here with the government or some other entity today. So if you can click the appropriate number, we'll see who we're talking to today.
Yep, we'll give everybody a minute or so. We've got about 80 people who have responded so far.
Oh, thank you, everyone.
I see somebody asked, what about parents? I would select other there.
And also thank you for saying that you're on the call. Appreciate that.
Other is number 5, for anybody wondering.
And the numbers on the survey align with that slide deck that shows the 1 through 5 organization types. Okay, Megan, let's take a look and see.
All right. Oh, can you see the results, Kristen?
I can. Okay, so 71% of you are developmental disabilities providers, 11% are from CCOs, 7% are from social care networks, 5% of you are from other provider types, and 5% are from other organizations. So thank you for doing that. Appreciate that. Okay. So that does help me frame some of the presentation a bit. So now we'll just go on to the next slide, and I'll just tell you a little bit about the organization that I actually work for, which is called Triad. So Triad is a partnership between 3 care coordination organizations, CCOs, and the 3 are Advanced Care Alliance, downstate, LIFEPlan CCO, kind of upstate through central New York, and then Person-Centered Services in Western New York. So the governance for Triad includes developmental disability providers statewide with an equal representation from each of those 3 CCOs. Together, the 3 CCOs serve about 62,000 members and were formed in 2018 at the same time the CCOs were formed as a way of exploring integrated care options together. So if probably many of you on this call know or remember that CCOs were meant to be the phase 1 of the transition to specialized IDD health plans. But as we stand today, the phase 1 is still where we're at. So in response to OPWDD creating the IDD provider-led integrated care model, these 3 organizations kind of came together to collaborate on what might be the most effective model. As of 2023, the 3 CCOs are now working together on this particular initiative, the 1115 NIHER initiative. So we'll just take a quick peek at the next slide, and that just shows you the Triad service area and where each of the 3 CCOs that I represent are actually located and what the service area is. So for those of you who don't know, now we'll just spend a couple minutes talking about what is a CCO. So I think I said before, care coordination organizations, and I'll just say CCO for the rest of the day, are specialized health homes for people with intellectual and or developmental disabilities who qualify for OPWDD services, or Office for People with Developmental Disabilities. So the care managers who work for each of the CCOs coordinate physical health, behavioral health, IDD services, sometimes called long-term service and supports, and other health-related social needs. There are a total of 7 CCOs in New York State that were formed in 2018 as part of this, again, phase 1 initiative. And as the state often does, there are at least 2 CCOs available in each county to offer members choice. Right now, today, the CCOs combined, the 7 CCOs combined, support over 130,000 members statewide. So just to take a quick peek at what the CCO services look like, and this little graphic that I pulled onto this slide actually comes from the ACA website, but it really represents the core services that most of the 7 CCOs provide. So care management and assistance with OPWDD enrollment are really at the core of what the CCOs do. So you can see some of the other kind of subsections of what we do that are related to those things. There are assessments, completing the life plan with the members, connecting them to services, getting appropriate consent, member and provider relations. We have clinical teams to support our care management. And then the 3 triad CCOs also offer a community resource tool that is available on each of our 3 websites that is available to help people locate community resources that support people with developmental disabilities. And so the link, again, to this tool is located on each of our 3 websites. So that's just a little kind of lay of the land to tell you where I'm coming from and the organizations that I represent. So now we'll kind of dive into the meat of what we're talking about today. And before I talk about the actual waiver amendment, I'm going to tell you what the 1115 waiver what the 1115 waiver is. So a lot of you on this call, probably 71% of you, I think it was, are very, very familiar with the 1915C waiver and all the OPWDD services. So the 1115 waiver is a Medicaid managed care waiver. And so sometimes when we say, oh, the people we support are not eligible, sometimes that's true because 1115 really is a Medicaid managed care waiver. And a large portion of the developmentally disabled folks under OPW have a fee-for-service Medicaid. So the 1115 waiver being a Medicaid managed care waiver, there are some assumptions built in. So under Medicaid managed care, there are certain exclusions and exemptions to who can and cannot participate in Medicaid managed care. So if you're someone who's exempt, then you can voluntarily enroll in Medicaid managed care. If you're someone who's excluded, then you're not eligible and you cannot enroll in Medicaid managed care. So as it relates to us and people with developmental disabilities, some of the DD exemptions are people qualified by OPWDD to receive OPW services, which today represents a little over 30,000 people of the 130,000 or so folks that we support, have already voluntarily enrolled in Medicaid managed care. So other people who are exempt, again, so they could voluntarily enroll in managed care if they want to, are residents of intermediate care facilities for DD. So we'll talk about who is not eligible to enroll for Medicaid managed care as it relates to the DD population. So I'm still back on the same slide though, Ann. So DD exclusions. So people who are dually eligible for Medicaid and Medicare cannot enroll in a mainstream Medicaid managed care plan, but they can enroll in dual special needs plans. People who are enrolled in a comprehensive private health insurance cannot enroll in Medicaid managed care. So if someone, is covered under their family Aetna policy or something, and all their medical expenses are covered, they are not eligible for Medicaid managed care. And then a smaller group of folks is people who are the fiscal responsibility of the state OPWDD. Sometimes we call that District Code 98. So those folks are excluded from managed care. So that's just to kind of give you a lay of the land again as we kind of talk through the amendment and what it is not, and who can participate and who cannot. So what the 1115 waivers do is give the state flexibility for innovative projects that advance the objectives of Medicaid. And that's exactly what Medicaid managed care is. So the New York State 1115 waiver is called New York State Medicaid Redesign Team. People call it MRT, Medicaid Redesign Team. And that's been in place since 1997, and it gets renewed in 5-year increments. So the waiver period that we're in now is from 4/1/2022 to 3/31/27. So people might remember that MRT was a way of transitioning many Medicaid populations and many Medicaid benefits from fee-for-service Medicaid into managed care. And so now, I talked about the exemptions and exclusions. We see very few Medicaid beneficiaries who are exempt or excluded from managed care. And if you're so inclined to look it up, if you just Google New York State Medicaid managed care exclusions and exemptions, you'll see the list of people who are exempt and excluded. Then I'll just say one more thing. Some of the amendments that you might remember from 1115 are DSRIP, some behavioral health service carve-ins, and now this New York Health Equity waiver, but there have been many more. So the overall goals of the 1115 are to improve access to healthcare for Medicaid beneficiaries, improve the quality of health services delivered, expand coverage to low-income New Yorkers. And now the new goal that's been added to the umbrella waiver is advancing health equity, reducing health disparities, and supporting the delivery of health-related social needs services. And so I'll pause there and check in with Megan to see if we have questions.
Yes, we do have one question. The question is, what if you are duly eligible Medicaid, Medicare, and enrolled in an ICF? Are you eligible for managed care?
So if any one of those attributes is an exclusion, then you're excluded. So if you have if I'm duly eligible, then I'm excluded. So if I'm in an ICF and I'm duly eligible, so if I was just in an ICF, then I would be exempt and I could voluntarily enroll. But if I'm in an ICF and I'm duly eligible falls under excluded. So that means I'm excluded and I can't enroll in Medicaid managed care. Does that answer the question?
I believe so. I'll let the asker follow up if there's anything else.
Okay.
So then we do have another question. Yes, that answers the question, Kristen.
Okay, great.
We have a second question. Is it accurate that about 40% of people in OPWDD services are duly eligible for Medicaid and Medicare?
That's my understanding too, between 40 and 50%. Yep.
Okay, looks like that's the last question.
Okay. So we'll go to the next slide and talk a little bit, start talking about the waiver amendment itself. So New York Health Equity Reform. So again, this is an 1115 waiver amendment. It was approved back in January for a total of $7.5 billion. So the end date on this particular waiver amendment aligns with the overall 1115 umbrella waiver. So the end date on this is 3/31/2027. So the ultimate goal of this particular waiver amendment will be to include these health-related social needs services that we'll talk about into the Medicaid managed care benefit package. And we'll talk a little bit more about that as we progress. But essentially, this is a demonstration to prove that this set of health-related social needs services will improve the health of certain vulnerable populations. And you'll see when we talk about eligibility that IDD is considered one of the eligible populations. So The three investment areas kind of that fall under this particular initiative to advance health equity and reduce health disparities and support delivery of social care are social care networks. So we'll talk a lot about what the social care networks are and what their role is. Strengthening the workforce is another large area, and then population health. So we'll talk a little bit about what most of those mean, and we'll talk a lot about the social care networks. Okay. So now I'm just going to give you an overview of these NIHER 1115 initiatives as they relate to mostly the DD provider community. So I'm not going to spend a lot of time on most of these, and then a few of these, like we said, there'll be multiple slides that follow this one, and we'll spend a fair amount of time. So there's one initiative that falls kind of under that population health bucket, which is called Health Equity Regional Organizations, or HEROES. And so these, what this will be is one statewide organization that'll be designated to do planning, data aggregation, do some regional needs assessments and plannings. They'll be responsible for pulling together stakeholders in each region and doing some value-based payment planning, and then publishing health equity data. So back a couple of years ago, when we started talking about and hearing about this initiative, we thought that there would be one hero in every region of the state, which there are like 13 regions of the state. And then the state, I think as directed by CMS, decided that there would be one New York State Global Health Equity Regional Organization. So what we're hearing now is that this particular organization will be announced in July, and that it will most likely be a collaboration of probably two organizations who take on this work. So what is our role as folks from the DD field is that we want to make sure that we are represented on these stakeholder meetings, both at the state level and at the regional level. So we want to make sure that there is a DD expert from the DD field, on both the statewide and regional forums and work groups. So it's important that our voice be heard in these forums. So social care network infrastructure, this is one that we're going to talk in depth about. But what we'll see is there are 9 to 13 of these that'll be selected based on how many get selected in New York City, is why there's variation there. And we'll talk later about exactly what the social care networks do and what their responsibilities are. And same with the next one, with the health-related social needs services. We'll spend a fair amount of time talking about what those services are and what the eligibility criteria is for those. Same with strengthening the workforce. We're going to spend a fair amount of time talking about what some of those initiatives are and how we can participate in those. Just to give you kind of a high level on the Medicaid Hospital Global Budget Initiative, this is an initiative that will only be available in certain downstate counties. So it's Bronx, Brooklyn, Queens, and Westchester counties. And this will be something that we'll talk about more at a more detailed level once the hospitals have been identified for this particular global budget initiative. And then we'll identify, which organizations might be best able to participate, in that particular initiative based on where you're located and kind of how many of the people that you support might also be patients at these hospitals. So we're not going to spend a lot of time on that. Okay, and then the next slide really is just information for you to show you what the funding levels look like for each of these initiatives under the NIHER program. So what this also kind of can do for you is provide you with the high-level timeline on the state's expectations for getting that funding out to the intended recipients. So as you can see right now, there was a DY, which is demonstration year 0, which that global budget initiative was intended to start, but I don't think it has, because I don't think the hospitals have been identified quite yet. But we're currently in demonstration year 1. And as you can see, the goal is to fund almost $2 billion for the designated projects that fall under DY1. So this is a really, really aggressive schedule, and it puts a lot of pressure on the social care networks and some of the workforce organizations, and we'll talk about that more. But just to let you know what that looks like and what the funding levels look like for each of the programs. Okay, so let's talk a little bit about the Strengthening the Workforce initiative. And I forgot to pause, so I'm going to pause again and ask Megan if there are any questions.
No questions at this time.
Okay. Okay, so we'll go to the next slide and talk about strengthening the workforce. So there are 2 major initiatives under strengthening the workforce, with the first being a student loan repayment program. So as DD providers, I would say watch out for this one if you hire these very specific healthcare professional types in your organization. So there's not a lot of, not a lot of variation on here. It has to be these very specific provider healthcare titles. So, but again, if you do hire these provider types in your organization, then this is something that you're going to want to pay close attention to, and hopefully you'll be able to use this to help with your recruitment of these provider types. So providers that take advantage of this need to make a 4-year commitment to the organization that they work at, or who hires them, and these organizations must be at least 30% Medicaid or uninsured in their patient panels. So there will be award criteria that comes out later. And this program will be administered by organizations called Workforce Investment Organizations. Another acronym for you, we call them WIOs. So be on the lookout for who the WIO in your region is, which are expected to be announced in July. The WIOs actually exist today, but what we're expecting is that there will be 3 workforce investment organization regions across the state. And right now there are many more WIOs than that, that exist. So we'll wait to hear who those organizations are, and then you'll want to connect with that designated, workforce investment organization in your region if this is an appropriate initiative for you. So the next Strengthening the Workforce initiative is called Career Pathways Training. So as you can see, over the course of this program, the state is planning to invest $646 million in this particular training initiative. So for us, what I would say is, and I have a question that I've submitted, is do our DSPs qualify under the frontline public health worker category? So I don't know the answer to that yet, but I would say all of you can ask that question too, and we can all kind of, put in a plug to have DSPs included as frontline public health workers in this program. So there are nursing and other professional and technical eligible healthcare titles that are available, and you may also hire these types of professionals in your organization. So again, what this does is provide education and participant support for holistic educational and professional placement support. So the money for this, just like the other one, goes directly to the educational institutions or to the other related institutions. These funding dollars don't go to the professional directly. So again, this is one to keep an eye on so that you can participate if appropriate, if you hire these types of folks in your organization. Okay, any questions on strengthening the workforce, Megan?
No. Doesn't look like it.
Okay, good. Okay, so now let's talk about the social care networks. So social care networks and the related health-related social needs services are the majority of the funding under this particular initiative. And so social care networks will be the organizations, I'll call them the core organizations, that will facilitate the provision of health-related social needs services across the state. So again, we'll talk in more detail in the upcoming slides about what those services are. But these will be kind of those core organizations who facilitate all things related to health-related social needs. So again, there will be up to 13 social care network regions, with only one social care network being awarded to each region. So where we're at right now with that is that the Department of Health is currently in the procurement period for selecting the social care network in each region. And I was really hoping that the announcement would be made before today, but it wasn't. And probably the social care networks on the line were hoping that too. So the announcement was supposed to be made the 1st of June. And then we were hearing it'll definitely be made before the end of the month of June. And now we're hearing it might go into July. So anyway, we're hoping to hear about which social care networks were awarded in each region. August, I saw that pop up. Oh boy, I hope you're wrong, Nicole. So we're in the procurement period, and hoping to hear, soon which organizations will be selected by region. So just to talk a little bit about what the role is of the social care networks, and we'll go through each of these blue boxes because they're all critical elements of the program. So social care networks will be responsible for establishing and maintaining a governing body and executive leadership for each region. The contracting piece is that it will be the social care network who contracts directly with each of the Medicaid managed care organizations in each region that will then facilitate payments for the Medicaid beneficiary eligibility. So as that relates to fiscal administration, what will happen is all of the community-based organizations who are contracted with a social care network for these health-related social needs actually get paid by the social care network. So like all of us don't have to contract with all the managed care organizations. We just contract with the social care network in our region. They contract with all the MCOs, and then they pay us directly. The social care networks will also be the ones who, for certain services that people who get fee-for-service Medicaid claims in for, they'll submit those, and then they will pay us. And in this scenario, we would be considered a community-based organization or a CBO, so that they would pay us directly for those services. So as it relates to IT platform data and reporting, the social care networks are responsible for contracting with a social care IT platform to manage referrals. So what does that mean? So to give you some examples of what a social care IT platform are like, Unite Us, Find Help. Some of the, there are some other, specific IT platforms like that across the state that have been developed in the regions, but those are the types of platforms. And so the social care networks will be responsible for managing referrals and enabling health-related social need data sharing through the SHINY, or that statewide health information network, or sometimes we call them RIOs or HIEs. So the social care networks are responsible for all those technical and social care platform responsibilities. Another one of their core functions is to build a network of CBOs. and then to help those CBOs or community-based organizations with capacity building. And so we'll talk a little bit more about exactly what that looks like, but essentially it's to make sure that they have a network of organizations in their social care network region who can provide the services that are available under this particular waiver as it relates to transportation, housing, healthy food, care management, screening, connection to and navigation to eligible services, but we'll talk about those. But it's their responsibility to understand the populations of people in their region, and and make sure that they have the right number of CBOs to serve those people. And then regional partnerships, the social care networks are also partnering with other organizations in the healthcare delivery system ecosystem in their region. So they'll develop partnerships with hospital systems and primary care and behavioral health, and again, the managed care organizations and kind of health homes and others that exist within their ecosystem in their region. And then again, they'll validate eligibility with managed care organizations and then navigate people to appropriate services. Okay, do we have questions on that, Megan?
Nope.
Okay, so let's take a look at what the social care network ecosystem looks like. And so some of these slides that I'm showing you are directly from a New York State Department of Health NIHER presentation. So you're welcome to certainly go out and look at those firsthand. But I didn't want to kind of recreate their graphics just kind of to add confusion. So some of these are their graphics, which this one is. So again, just to say, developmental disability providers will be considered a CBO in the social care network ecosystem. And when we look at this ecosystem, and you can see all the different organization types that are part of the social care ecosystem, this is a way of bridging the gap between IDD service providers and the rest of the healthcare delivery system. So I think our participation in this initiative will really be a step closer to whole person care for people with developmental disabilities. So this is just kind of a snapshot of what that looks like for you. So let's kind of talk about the role of community-based organizations as it relates to the social care networks. So CBOs will be nonprofit organizations unless somehow otherwise exempt by New York State. So you must be able to be an organization who can screen for health-related social needs, do social care navigation, and then provide health-related social needs services. You must have at least one service location in the social care network region, and you should employ social care navigators, people who will screen members, validate their eligibility, and perform closed-loop referrals in the social care network's closed-loop referral platform, whatever it is that they decide to use. You have to demonstrate that you have cultural and linguistic competency, and you have to have a willingness to engage and to be trained on the social care network's data and IT platforms. You have to be willing to accept referrals and provide services and collaborate with the social care network. So that sounds like a lot, but also remembering that it's the role of the social care networks to provide capacity building to help you with these things. So one of the critical pieces here is to have that willingness to engage and willingness to be trained on these things. So if you feel like you're almost there, but you're missing one piece, you should still engage with that social care network in your region so that you can, talk to them about, what your needs are to be able to serve people under the program.
Kristen, we've got a question in the chat.
Okay.
Okay, so there was a forum at Columbia recently where a CMS administrator emphasized that for someone to get social care services, The individual must first have a qualifying medical condition. The medical condition would not be IDD, but a condition such as diabetes, asthma, etc. Is that correct?
So yes, but is the answer. So we understand that there will be some clinical eligibility criteria that will be attached to some of these services. It hasn't been released yet. And in the next couple of slides, we're going to talk about the medium-sized list of things that haven't been shared publicly yet. And clinical eligibility criteria is one of them. So yes, I heard the same thing, but I haven't seen the specific criteria yet, and I don't even think that it has been shared broadly or even a little bit yet. So what's supposed to happen is when the Social Care Network awards are made, that there will be a program manual that goes along with that, and eligibility criteria and further definition of the social needs services are something that'll be included in this program manual that's TBD. So yes, you're right, but I don't know what they are. So social care network regions, just to give you a quick peek at what region you might be in. This is how the state has divided the regions. And so you can see technically there are 9 regions, but in New York City, which is all called Region 4, but there are 5 different regions within Region 4. So there could be anywhere from 1 to 5 social care networks designated for New York City. Now, the numbers that you see next to each region are the allocated social care network, what they call infrastructure dollars for each region. So this is the money that the social care network that gets designated will use for their own central operations and for the capacity building to help the CBOs in their network be able to provide the services through this waiver. Are there questions on that, Megan?
Nope.
Okay. And so the next slide are, I'll say, the social care network applicants that I am aware of. So there may be others, but these are the folks that I'm aware of. And as you can see, in most of the regions, it is a competitive process. And I know of at least 2 organizations from each network, except for I think 2 that there is some competition. So once those awards are made, as Nicole says, in August, then we'll certainly let you know who the awardees are and how to contact them. I would say that if you are not already engaged with these organizations, it wouldn't be bad to reach out to them now, even before the awards are made. And not only wouldn't be bad, but it'd probably be beneficial to be connected to these organizations sooner rather than later. So we're going to take a little survey next. So I'm interested to know if your organization is currently participating or engaged with one of the social care networks that I showed you on the previous slide. And it's just, Megan will put up the little survey, but if you are engaged with one of them, then just go ahead and click yes. If you're not, go ahead and click no. And if you're, somebody who's not a CBO, then you can just click NA. And for my social care network partners on the phone or on the line, please go ahead and put your contact information in the chat for interested providers to contact you. I will tell you that I would click, if I could, I would click 3 times because ACA, LIFEPlan, and person-centered services are all engaged with their local social care networks.
We'll keep the poll open for another 15 seconds or so.
Okay, thanks, Megan.
Yeah.
I am glad to see all the yeses, so that's wonderful. And just so everyone knows, both ACA and LIFEPlan did a provider newsletter article that I wrote about 1115. And so you can go back to both the ACA and LIFEPlan websites to find that provider newsletter. And I did include contact information for the social care networks that I knew of in that newsletter too.
I will drop the websites for the provider newsletter archives in the chat.
Thank you.
Yeah.
Okay, I think that's good, Megan. And so, yes, I'm really happy to see about 42% of you are engaged with your social care network, and about 32% are not, 26% are NA. So if you're not engaged and you need help, or you'd like to make me, have me help make a kind of a soft introduction, I am very happy to help you connect to the social care network in your region. So feel free to just reach out to me to do that. Okay. So let's talk about the 1115 waiver amendment for people with developmental disabilities. And so I'm rounding here, but so we have about 130,000 people with developmental disabilities currently receiving OPWDD services. What we know is that about 30,000 of those folks are in Medicaid managed care, because kind of back to the other conversation, those are people who are exempt from managed care, but they can voluntarily enroll. So about 30,000 or so folks did voluntarily enroll in a Medicaid managed care product. So what that means is we have about 100,000 people who are in a fee-for-service Medicaid program, or fee-for-service coverage. Sometimes we call that straight Medicaid or fee-for-service Medicaid. And as someone said earlier, we have probably 40 to 50% of people are dually eligible. So people who are enrolled in fee-for-service Medicaid are not eligible for 1115 initiatives, including this health equity reform waiver amendment. They're not eligible for value-based payment innovations under managed care. They're not eligible for in lieu of services, which provide some innovative services under Medicaid managed care. And so there are, a number of things as it relates to 1115 waiver that people who are in fee-for-service Medicaid are not eligible for. And of course, that's not just people with developmental disabilities. That's anyone in a fee-for-service Medicaid program. So some new interesting data is that as part of this social care network, and we'll just go back to the previous slide for just a second, as new information as part of the application process for the social care networks is that the Department of Health identified within each region, I'll call it special populations that existed within each region. So we'll talk about what the other special populations of folks are, but as it relates to people with IDD, there are about 230,000 people with IDD identified in Medicaid managed care today. So as we talked about in the bullet above, we know that there are about 30,000 of those people are getting OPWDD services today, which says about 200,000 people that the state has identified with IDD are not getting OPWDD services. So that kind of makes us ask ourselves, well, how many of these people might be eligible for OPW services? And how did the state identify who these folks are? What was the eligibility criteria? What was the algorithm, that was used to identify these 230,000 people? And then you might say, well, can the system handle more people? And, what will we do? So as it relates to the people who are still in fee for service, this is a health equity waiver. And we would say from a DD perspective, this is a health equity issue that our DD population is not eligible for this particular set of services. So if we go to the next slide.
We've got a question in the chat too.
Right. Yep. Let's do that.
So, so this says from somebody who has attended the DOH advisory panel on managed care about 2 years ago. They asked, and panel members supported getting the data from DOH regarding the percentages of OPWDD people in managed care. They did not get detailed data, but it seemed reasonable to advocates that many of those in OPWDD were auto-enrolled in managed care because family members had Medicaid for economic reasons. And can you comment on that?
I think that's probably fair. I think that's a fair assumption that people who are in Medicaid managed care are probably there because they have family members who are also on a Medicaid managed care plan, or they have family members who are in the commercial side of the plan, and then this family member qualified for Medicaid and are also, or maybe the county DSS office helped them apply to be to get the Medicaid managed care. So, but again, like we know only 30,000 people getting OPWDD services are in Medicaid managed care. So these 200 and first I want to just pause and see if I'm not sure if I answered that, and maybe I need to open up the chat myself and take a peek. Okay. Yeah. And okay. So this is Ralph, right? So what I would say about that too, Ralph, is that we've had some conversations with the Department of Health about who these, who the folks are that were identified here. And what we know is that the Department of Health, the New York State Department of Health Special Populations Bureau is working on an initiative which they generally call the OPWD lookalikes, because they wanted to get a true understanding, like you said, of people who might have a developmental disability who are outside of the OPWDD system. So I don't know about the auto-enrolled piece. I think it's difficult to get auto-enrolled, but but they could have been. So.
And then we do have a comment in the chat. Many people were encouraged to enroll in order to get access to providers without fully understanding the decision.
Yeah, that's true. So that's from
from Lori. Yes. Yep.
Yeah. Okay. So just to kind of continue with this slide and what this data is telling us. So this shows us, what the state is considering or thinking the developmental disability population by, we'll call it NIHR region is. And then interestingly, the last column in this data set shows us people who have a developmental disability and behavioral health, we'll call it comorbidity. So predominantly this group of folks was identified through claims data. So I'm sure they're looking at diagnosis codes, procedure codes, place of service. Was the service delivered by one of your organizations in Article 16, others. So so I'll be interested to get additional details on, how these folks were identified. But right now, that's what that's what we're thinking. Do we have a question, Megan?
We had a question come through right as you were listing the ways that these individuals may have been identified. One person asked if they were identified based on diagnosis code. So I just checked, to make sure you answered the question.
Yeah.
All right.
Yeah. So when you look at this number, and it's 230,000 people that the Department of Health has identified, potentially with a developmental disability diagnosis, you might say, so who's supporting these people? Are these people eligible for OPWDD services? If they are, who will do the assessments on these on all these folks? Can OPWDD handle an influx of enrollment? Those kinds of questions might be coming to your mind. So what I would say is, because we're not completely clear on the algorithms, or like I said, the criteria that was used to arrive at this number, if we just make a conservative estimate or conservative assumption, and let's say 5% of these 200,000 people are eligible for OPWDD services. So that's 10,000 people. 10%, 20,000 people. So if we're being really conservative, we're saying, let's just make this assumption, and that's, maybe 10 to 20,000 people who might qualify for an OPWDD, for OPWDD services. Then you still might be scratching your head and saying, can the system support this? So if you are, then you're not alone. So I'm just going to go to the next slide, and we're just going to spend 1 minute here just to say that there are a group of people who are leaders in the developmental disabilities field that have kind of written a paper that documents the current state of the DD system today, just looking at the history, maybe a case for change. This is not a solution statement. But what it is a 4-page document that articulates the belief that the current system is having difficulty meeting the more complex needs that people have today. So about 150 executive directors and CEOs have signed on to this, what we call a whole person support statement. And if you're interested in learning more about it, I can send you the paper, and I can connect you with someone to talk to. So that's just kind of it about that. But I just wanted you to be aware that there were some, some folks in the community that were thinking about this even before the NIHR waiver. All right, so let's finally talk about the health-related social needs services that are available under the waiver. So there are 2 sets of services, and they're called level 1 and level 2, or sometimes people say basic and enhanced. And so the level 1 services are for all Medicaid members, fee-for-service, managed care. Everybody is eligible to receive a health-related social needs screening and navigation to pre-existing state, federal, and local programs to address their needs. And so that's anything that exists today. Maybe we could help people navigate to OPWDD services. We can help people navigate to SNAP and WIC and HEAP and all the services that are out there and available today before this waiver gets operationalized. Level 2, or the enhanced services under this waiver, are available to people who are enrolled in Medicaid managed care. They screen positive for an unmet health-related social need screen, and they meet one of the level 2 criteria. So to the point of the person who asked the question earlier, this must be evidence-based and medically appropriate. So yes, so there will be some medical or clinical criteria that's woven in. So just in the blue box, some of the, or these are the level 2 eligibility criteria from a population health perspective. So high utilizers, health home, this is the adult and child health home, not CCO health home, enrollees, pregnant people, and up to 12 months postpartum, post-release criminal justice, juvenile justice, children under age 6, children under 18 with a chronic condition, people with substance use disorder, people with IDD, and people with serious mental illnesses. And then if you look at the gray box, the list of unknowns is the fee schedule. So, while we know that the state will issue a fee schedule that includes kind of a fee for service fee for each of these services, including the screening and navigation, and then all the health-related social need services that we'll detail here in just a sec. But we don't know the fee schedule. We don't really know the health-related social needs service definitions. We have some idea of those. As we talked about before, we haven't really seen the definition of IDD, and we haven't really seen the clinical criteria. So while we have some information about the services, there are still a number of unknowns that are supposed to be released at some point after the social care networks have been announced. Okay, so let's take a look at the kind of the buckets of health-related social needs services. And so you'll see my little bubbles that I put at the top. And essentially where you see triad, all I'm saying there is that if we go back to the conversation about the services and kind of core functions of the CCOs, what the triad CCOs would do are the health-related social needs screenings and case management. What all of you could do is any of these 5 buckets of services. So, so what I would do if I were you is I would take a look at the detail that we do have about each of these particular service areas and see what best suits you based on maybe services you provide today, maybe services that you're interested in providing. And then you would work with the social care network in your region on the capacity building that would allow you to incorporate these types of service offerings into what you do today to serve people either with IDD or maybe you serve other people. So if we think about the eligibility criteria in the previous slide, maybe you serve and support folks with some of those other eligibility criteria. And you can, as we're thinking about this, you can think about all of the people who you support in your organization today and how these relate to all the populations of folks that you might serve. But again, as triad CCOs, we can screen people, and then our goal would be, if we are screening individuals that the social care network thinks might have a DD diagnosis, then we can refer them back to your organizations or make the recommendation to the social care network, that we think this, particular person might, be a person who has a developmental disability and maybe they need housing supports. And we would make a recommendation that we know an organization who specifically supports people with developmental disabilities. And, we would funnel those folks back to you for support. And Megan, we have a question.
Yes, there is a question from Yvonne of Care Therapy Group. We specialize in nutrition/eating disorders. How do we go about being used as a resource?
Perfect question. And we're going to talk about that in just a little bit. But what I would say is, depending on where you are, and I'm sorry, I don't know I don't know where you are geographically, but you'll want to connect with the social care network in your region and start talking to them about the services you provide. And then, they will kind of guide you through the process about how you become more formally engaged with them. So right now you can kind of informally be connected to social care networks. And then over time, there'll be, specific contracting and those sorts of things that the social care network will need to do to bring you into the program formally.
So Kristen, this provider, they provide telehealth services and they are located in Orange County.
Ah, okay. So there will be, right now there are 2 social care networks who have applied in the Hudson Valley. And so, we can get you connected to them. I'm going to pause just for a second, take a little drink of water.
We're getting some really great questions overall throughout this. So thank you, folks. Keep asking them as they come up.
Okay, great. Any other questions, Megan?
Nope, that's it at this time.
Okay. So that's kind of just shows you the bucket of questions. So I will tell you, as it relates to our field, the state has selected the CMS Accountable Health Communities Screening Tool. And we actually did have some concerns about that particular tool as it relates to developmental disabilities, and how is that tool going to narrow down the needs of people with IDD. So I do have a question into the state about that too. So in addition to this Accountable Health Communities Screening Tool, will there be other questions that help identify that somebody has one of those kind of 10 or however many they are in the blue box in the prior slide, eligibility criteria? So yeah. How can DAHAB participate? I saw that pop up. So again, I think what I would do is just contact the social care network in your region and either make sure that they understand the services that you provide today, and then you also understand the services that are available under this program, and whether you have to modify services the way you offer today, or or whatever the case may be. You would just kind of work that out with the social care network. Maybe you would need to ask them for some capacity building, like kind of infrastructure support, whether it's dollars, training, IT, those sorts of things, to help you be able to offer services under this waiver. Okay. Any other questions, Megan?
Nope, that's it.
Okay. Now the next 2 slides are just really a little bit more detail on the services, so you can see, a little bit more how your services that you offer today might align with these services. But I would still say that if you don't align perfectly, that you should still reach out to the social care network in your region to understand these a little bit more, and so that they understand you a little bit more. So. And we'll actually skip right down to slide 28. Yeah. So I just wanted to show you at a high level the member journey under this waiver. And so essentially what would happen in this first green box under screening is that the state wants every Medicaid beneficiary in the whole state to be screened for health-related social needs. Again, it's, do they need housing and utilities services? Do they have a food insecurity? Do they have a transportation need? Education, employment, interpersonal safety. So those are all the questions that kind of are asked under that CMS tool. So if the member does have a need, then the surveyor would ask that person if they want assistance with that need. So some people might have a food insecurity, but they're really not interested in seeking help for that. So, that'll be part of the process is, do you have one of these needs and would you like assistance? So if the person says yes, then the surveyor, whoever that organization is, will make a determination on the eligibility for those enhanced services that we looked at in the couple of slides before. So they'll get the member information, from the MCO. Are they part of the Medicaid managed care organization? Because they would have to be eligible for the level 2 services. And then they would provide the screening results to the social care network. So if the person was not eligible for those extended services, then the organization can help navigate them with what we call navigate them to level 1 services, which are those things that I said before, like SNAP and HEAP and WIC and all the other existing services, that are available at the community, state, and federal level today. Or they would be navigated to those level 2 services, which could be, if it's a person with IDD who has one of these health-related social needs, they could be then, potentially referred back to you as an organization who provides those services. So that's what that looks like from the member's perspective. And then the next 2 slides, I really just kind of broke that down a little bit. We'll stay on this one with Medicaid managed care to show you what that looks like for people with DD. And I think I saw a question pop up, Megan, right?
Comment. And a question.
Okay.
The first question, how do we as a CBO know if a screen has already been completed by another agency for an individual?
Yeah, that's a great question. So when we talked before about the roles and responsibility of the social care network, and then at the very beginning, we talked about what those health equity regional organization or planning organization would do. There's a whole technology component to this program. And so, there are conversations and plans in place right now for where the information about health-related social needs screening will live. And so, so will that information live, on the at the SHINY, the state, HIE, will it live on the social need referral platforms? It might live in multiple places, but I think that's part of the planning that'll happen at the regional and state level is where that screening information will be housed so that people aren't screened multiple times. So I don't have a great answer for you, except for that it's that it's part of the solutioning.
Okay. And then the comment is from Ralph. This is such an excellent presentation, more than what I've seen so far publicly from DOH or what Leading Age put up on the web in May. And then Ralph shared a link to the CMS assessment tool.
Oh, thank you, Ralph. Thank you very much. Appreciate the comment. Okay, so just to kind of go through this workflow a little bit, to say kind of what's happening for people who do have Medicaid managed care. So we know in the DD world, it's those 230,000 people. And if we go to the top bucket of those, we know about 30,000 people are enrolled in CCOs today under OPWDD. And what I would say about that is that what we would ask of the social care networks is that hopefully they'll be able to have information to identify which members are enrolled in CCOs and then enroll those folks right back to their CCO. And I'm not talking about just the 3 triad CCOs, all 7 CCOs. So we don't want to add complexity to the lives of people who are enrolled with CCOs by assigning them yet another care manager or yet another person to complete screenings and assessments. We would really hope to find a way that social care networks can be provided with which people are enrolled with CCOs and refer them back to the CCOs to do these screenings. So for those 30,000 people, that's what we hope would happen. And then if people do have a health-related social need, we would, refer that person appropriately. And then, as in all cases, because of the work that we do, our core function at the CCOs, we would always be evaluating people to see if they meet OPWDD waiver service criteria. And then we would also, as a CCO, have to be very cognizant about what we call double dipping. So we don't want to be providing care coordination under waiver to someone we're already getting paid to do CCO services. So we would continue to do our core work under the CCO, and then evaluate if that person has other needs that are not met under OPWDD. And I'll pause because I think Megan has a question from someone.
Yes, this is from Arthur Pilevsky. First off, Arthur also agrees it's an excellent presentation. One of the slides noted that one of the services a CBO can provide is to navigate. If that means navigate the system, isn't that the role of the CCO?
Yes. And so that's exactly what I'm saying. And I'm glad that you said that, because maybe I didn't say it clearly, but what I would say is that all CCO enrollees should always be receiving these services from their CCO. So that'll be outside of this NIHER waiver. It's the work that we already do. So Arthur, I think what I would like to see happen is that, if someone's already enrolled with a CCO and they're already having, they already have someone who does this work for them, we want to make sure they don't get referred outside of the CCO to another community organization who would be duplicating the work that the CCO is doing. So the CCO won't get paid double for that, but we just want to make sure that the CCO care manager is the one who's responsible for doing that work, and that the person doesn't erroneously get referred outside of the CCO for that same work. Does that make sense?
Yes, it sounds like it. Arthur says thank you. And then we have a question from Carolyn Wimber. It sounds like the majority of people with OPWDD eligibility will not qualify for any level 2 services. Is that correct?
That's right. If they have fee-for-service Medicaid, they don't qualify. Yes, I would consider that a health equity issue if anybody asks.
Great. And that's the last question for now.
Okay, great. So just kind of staying on this Medicaid managed care workflow, if we kind of go to the bottom of the workflow, and those are the 200,000 people in Medicaid managed care who are not enrolled in OPWDD, not enrolled with a CCO. So what do we think will happen with those folks? So what might happen is the social care networks will either refer or organically screening might happen somewhere out in the healthcare delivery system, or we as the triad CCOs can perform that screening for those folks. So what we want to encourage here is that people with a developmental disability, whether they get that screening done by a CCO. And so just to be clear, what I'm suggesting here is that the CCOs might be able to screen for people who are not enrolled to them, because essentially that's what we do today is our enrollment function. So, as our enrollment function, we're always, serving and supporting people who might be eligible for OPWDD. So we certainly serve people in a care management function for those who are already qualified and already eligible through OPW, but we're always helping people who might be eligible through our enrollment function too. But whether they're, folks are screened by us or whether they're, like I said, screened somewhere else in the healthcare delivery system. If somebody, let's say a hospital system, PCP, whoever, thinks that somebody might be eligible for OPWDD services, then we'd love for them to refer them back to the CCO for help with that OPWDD enrollment process like we do today. And then the rest, the same process would continue, would screen, for those health-related social needs, and then work with the social care networks to refer appropriately, go through the whole eligibility process, and so on. Any questions, Megan?
We did have one. It looks like another participant was able to help answer it, but just in case anybody else is wondering, the original question was, I may have missed it, but where do I go to find out about my social care network in my region?
You didn't miss it, and we can provide that information. But there was a newsletter article, and I think, Megan, did you pop in the link to the newsletter article for LIFEPlan and ACA? And that does give a link to the social care networks that I'm aware of.
So I shared where we were going to share the webinar, but let me just double check and make sure I'm not missing something, because I did not see another link. You know what? If I can't find it now, we'll send it out in an email, because just so everybody knows, after the presentation, once we have the recording ready, we're going to share a link to the recording and a copy of the slides with everybody on today. So Kristen, if I can't find that, I'll share it in the follow-up.
Okay, perfect. And that should give you the link for how to contact the social care network in your region. And thank you, Ami, for giving yours. And so the next slide is just a little bit of a different variation on that. And this is for people with, straight Medicaid or fee-for-service Medicaid. So, we knew the number of people who have Medicaid managed care that we think have a DD diagnosis. On the fee-for-service side, I have no idea how many people might have a DD diagnosis. So, but what would happen is, what we do know is people who are enrolled under OPWDD, enrolled with CCOs, there are about 100,000 of those folks. And so what would happen is, those folks are already receiving CCO services, and they're probably already receiving some kind of waivered services with one of you. But what we would do is complete the screening and then help navigate them like we do today as part of our regular job to services that they need as it relates to health-related social needs. And then for people who are not receiving OPW services, not enrolled with CCOs, again, we would be willing to help with the screening for those folks and do kind of an OPWDD eligibility assessment, and then help people as appropriate with that OPWDD enrollment like we do today. Any questions? Okay. Okay, so now we'll just take a look at the 1115 NIHER timeline. So this is from the state, and it sounds like we might be falling behind some more. But essentially, like if you just kind of scoot up to August 2024, what was supposed to be happening in August 2024 is the social care networks would have been designated a few months before, and the state would have been contracting with social care networks. And then some of the training program under workforce would have began, and that AHEAD application is due, that has to do with a primary care model, would have started, but it seems like we might be a little behind. So what we thought would happen is in October, health-related social needs services would begin, and we would have been contracted with social care networks, and that capacity building would have happened. So we'll keep an eye on this timeline. And somehow, maybe through newsletter, I can keep you posted on what's happening.
And we do have a comment from Nicole Hall saying that Amir's announcement still emphasized services beginning in October.
Oh my goodness. So just so folks know, Nicole is part of one of the social care network applicants in Central New York. So thank you for that inside info, Nicole. And it sounds like the social care networks are going to have their hands full by staying on track with this timeline. So if anyone has friends who work at social care networks, then we probably won't see them this summer. So okay. Okay. Are there any other questions?
Nope.
Did I miss any? Okay. So next steps. So what I would say about next steps is please contact your regional social care network. Take a look and compare your service offerings to those health-related social need services that are available. Keep an eye on those workforce investment opportunities for those of you who hire people with those specific titles. Stay connected with those social care networks in your region, and please feel free to contact me directly with any questions. You can contact your directors of provider relations or contact me directly, and I'll pull them in with any questions that you might have about this waiver and how you might be able to participate. I think that is it. So thank you.